Hanley Foundation, where our mission is to eliminate addiction through prevention, advocacy, and recovery support. Thank you for joining us for the 5th installment in our Recovery Leadership Institute's Summer Recovery Leadership Series. Just as a reminder, if you've been joining us these past few weeks, you'll know that after tonight's discussion, we will have a moderated question and answer period with our speaker. Please go ahead and drop your questions into the chat and we'll be sure to answer them at the close of tonight's presentation. Also, just as a special announcement, for your health and safety, we will not be continuing the series live and in person after tonight. All other sessions will be happening virtually only. So in your registration, please be mindful that we will not be meeting at the hub for the next 2 presentations. Now, as we continue, I just want to take this time out just to thank our sponsors and our collaborators for this event. So a special thank you to the Palm Beach County Hub, our very own Recovery Community Center here in Palm Beach County, as well as Palm Beach County's Community Services Department. Now, tonight, our topic will be co-occurring disorders, and we have the pleasure of having our guest speaker, Marsha Martino, Executive Director of NAMI, Palm Beach County. Marsha has been involved with NAMI since 2010. She is a NAMI Provider Education Instructor and a NAMI Family-to-Family State Instructor. She served for 4 years on the NAMI Palm Beach County Board of Directors, and in 2015, she was selected to serve as their Executive Director. NAMI, the National Alliance on Mental Illness, is a statewide as well as national organization with affiliates all over the country. Marsha's prior work experience includes 25 years of developing and managing programs in the state of Maine for individuals with neurological issues. In the state of Florida, Marsha has managed programs for individuals living with developmental disabilities, cystic fibrosis, as well as adult and juvenile justice issues. She has a passion for coordinating and developing resources for individuals who have multiple diagnoses and complex needs. We are grateful to have her here tonight, and join me in welcoming Marsha Martino.
Thank you. Thank you. All right, well, thank you. Thank you for having me here this evening. It's a topic that's near and dear to my heart, and it's a pleasure to speak to everyone about it this evening. And it's not going forward. How about this? Okay. So we're going to talk about co-occurring disorders, and the disorders we'll be talking about primarily are mental illness and substance use disorder. So what is mental illness? Mental illness is a condition that affects a person's thinking, feeling, behavior, or mood, but it impacts their day-to-day living, and it might also impact their ability to relate to other people. So what the prevalence of mental illness, it's more common than people really think. That 1 in 5 people experience a mental illness each year. Now it's 1 in 20 who experience a serious mental illness, and that's usually when someone talks about mental illness, that's what someone's thinking of, a serious mental illness, which would be bipolar disorder, schizophrenia, or major depressive disorder. But it's 1 in 5 people who experience a mental illness in a year, and that's 1 in 5 of all of us, all of you. And typically, we don't see the people, or people often don't acknowledge that they're being treated for a mental illness because of the stigma around it. So we don't particularly know of the people who are living well with a mental illness. 50% of mental illness begins before the age of 14, and 75% by the age of 24. The 50% beginning by the age of 14 is often kind of retrospective when someone is having difficulties in their teens or 20s and looking back Sometimes you'll hear someone say, yeah, you know, that anxiety was really a problem since the person was 10, or there were always kind of symptoms that kind of went under the radar. So, you know, again, that's often retrospective. It's not that 50% of people with mental illness are treated before the age of 14. But the 75% by age of 24, typically symptoms of mental illness that are going to require treatment will emerge in late teens and early 20s. A substance use disorder, it's a condition where there's uncontrolled use of substance despite the harmful consequences of it. 10% of adults have substance use disorder at some time in their life, and 33% have an alcohol disorder at some point in their lifetime. And the co-occurring then is the co-occurrence of a substance use disorder and a mental illness kind of happening at the same time with someone. Other terms, a term that used to be very common was a dual diagnosis and comorbidity. They're comorbid conditions. So mental illness and substance use disorder, they co-occur, and we know that about 50% of individuals who live with a mental illness also have a co-occurring substance use disorder, and 50% of individuals with a substance use disorder have a co-occurring mental illness. But there are other co-occurrences that we will see in this population, not necessarily a diagnosis, but these are issues that come up very frequently when we're talking about people with co-occurring issues. Homelessness is very common, incarceration, the incidence of domestic violence is high, traumatic brain injury, a trauma history. Many people with mental illness and substance use disorders have a very significant trauma history. And then they run into things like parental rights issues, fractured family dynamics, and developmental disability. So compounding the situation of a substance use and mental illness, we have many other things that individual is often dealing with. So you look at someone who has a mental illness, a substance use disorder, and a handful of those other issues, and that person reaches out for help, or their family member reaches out for help. What kind of message do they get? This is near and dear to my heart. I've reached out for help for a loved one, and these are very common responses that you would get in relating the history or the issues that your loved one is dealing with. They're like, whoa, you need a higher level of care. This is not something that we can deal with. You have a complex case. And sometimes it's, well, go take care of that mental illness, get that stable, and then come back and deal with your substance use. Or the other way around, get that addiction under control, and then we'll deal with the mental health issue. Often, staff are not trained to handle your kind of case. And then when there are complex issues going on and the individual is having a really difficult time, looking at their ability to handle, to tackle treatment for those, we can't help someone who doesn't want help. A phrase that I've heard many times. I like to say, I thought you did motivational interviewing. We can't help someone who doesn't want help. And then sometimes when a family member is reaching out for help on behalf of their loved one, they will get the comment that the family member, the person with the addiction or the mental illness, needs to make that call themselves. They have to show that they're motivated enough that they will pick up the phone and call and ask for help. So what happens is at the end of that encounter where someone is reaching out and asking for help, they end up feeling more hopeless than when they reached out for help. And that's something that is just, in my mind, unacceptable. So talking about mental illness and substance use disorder, what are the common factors? You know, what is this issue of co-occurrence? Well, there are two factors that are issues with both mental illness and substance use disorder. There's a genetic vulnerability and there are environmental factors. And sometimes people relate to that, relate that like there's the gun and the trigger. So the gun is loaded with your genetic vulnerability, your genes, and then the triggers are environmental triggers that may put those genes into action. So starting with mental illness, the genetic vulnerability in mental illness. So they've done studies with twins who were separated or adoption studies to see kind of where the genes follow that individual. And they know that schizophrenia, autism, manic depressive illness or bipolar disorder, it's called sometimes, major depressive disorder, attention deficit, hyperactivity disorder, and panic disorder, they know that these are disorders that are hereditary, that there is a hereditary component to them, to all of those disorders. And in substance use, they know, again, with the family studies, they know that they believe that almost half of a person's risk of becoming addicted to nicotine, alcohol, or other drugs depends on that person's genetic makeup. And then there are the environmental triggers. And these are the triggers that you would see in both mental illness and in substance use disorder. One is ACEs, adverse childhood experiences. If you don't know what that is, I really encourage you to look it up. It's amazing. There's been amazing work done on how adverse childhood experiences impact a person throughout their lifetime, not just their emotional or mental well-being, but their physical well-being as well. Very, very interesting work done on that. And then trauma is another trigger for substance use or mental illness. And then stress. And stress can be positive or negative. Sometimes it's the person going away to college, living away from home for the first time. It might be a divorce, but it might be a marriage. It might be the death of a loved one. It might be the birth of a baby. You know, there are just things that are big changes in someone's life that can be triggers and trigger these genes into action. So the co-occurrence then of substance use and mental illness. It's tricky in several ways. One is that it's hard to have an accurate diagnosis when they are co-occurring. There are medications that are prescribed for mental health issues, for example, benzodiazepines, that can be problematic. People can become addicted to benzodiazepines. Self-medication is common. So someone who is experiencing symptoms of mental illness, or they may be experiencing anxiety, depression, it is more socially acceptable in our society for people to self-medicate than it is to go to a psychiatrist, get assessed, and get medication, or even go for therapy. Hopefully some of that is changing, but for a young adult, 18, 19, 20 years old, drugs and alcohol are readily available to them. So they can, they're having a bad week, they can self-medicate with drugs or alcohol. And then psychiatric responses from drugs or alcohol. So, alcohol in itself is a depressant. Amphetamines, so MDMA, THC, can cause psychosis. I mean, not in everyone, but for some people that they do trigger psychosis. THC, the ingredient in marijuana, causes paranoia. If someone already has issues with paranoia, it can really manifest in a pretty detrimental way. And then sleeping and not sleeping, those are very common symptoms with any mental health issue. And drugs and alcohol exacerbate those issues one way or the other. So the treatment of the co-occurring disorders, how do you tackle this? What do you do when someone has mental illness and a substance use disorder and a handful of those other issues. What do you do? Well, first think about what kind of outcome are you looking for? We want a system of care that effectively meets the needs of the individuals in the family with all of these various things going on. And the bottom line is we want them to be able to have the happiest, most hopeful, and productive lives they possibly can. And the way that that can happen is by addressing all of the issues that are impacting that person's life. So there's a gentleman, Ken Minkoff, who with his wife, whose first name I don't know, Klein, developed this comprehensive, continuous, integrated system of care model. I heard Dr. Minkoff speak at a conference quite a number of years ago and literally brought tears to my eyes because it was like, this is what we need. This is what should be happening for our loved ones, ourselves, for people who are in treatment, who have multiple issues. So this model, it's based on 8 consensus best practice principles. It's an integrated philosophy, so it's treating the whole person. And it makes sense both for someone with mental health issues and in the mental health system, within the mental health system, and within the substance use disorder treatment system. It makes sense for both. So the assumptions in the model are that behavioral health and other related service delivery systems need to be organized at every single level. So that's at the policy level, when you're doing procedures, at practice, what your staff learns, everything that is done, all the resources need to look at an integrated model. It centers on the needs of the individuals and families needing services. So it's not a one-size-fits-all. You look at the needs of that person, that long list of things that person needs, and you center their treatment on that. It's welcoming, it's empowering, and it's helpful to the individual. It builds partnerships throughout the system. So no one leaves feeling like, I'm a mess and I can't be helped. And unfortunately, that is a message that many people, particularly people with complex needs, that's the message they get often when they fail out of treatment. So the goal of this system, this comprehensive model, is to have a system of care that it's welcoming, it's recovery oriented, it's integrated, it's trauma informed, and it's culturally competent. So the assumption is that people entering services will have multiple co-occurring conditions. And that is just a fact. It's the person who just has one thing going on is just very rare. A mental illness impacts not only that individual, but everyone around them, particularly loved ones and family members. And the same is true of substance use. When both are happening, of course, people around that individual are impacted. And so all of those conditions, need to be addressed in order for that person to be able to move forward. And they need to be welcomed for care. They need to be inspired with hope, engaged in partnership to address each and every one of the conditions in order to achieve vision of hope and recovery. They have to believe that, not that I'm a complex case, they have to believe that here are the issues that I'm dealing with, and they can be attacked. We can work on those. I can get help for each of those issues. So this system of care, it's based on 8 basic principles. And the first one, number 1, co-occurring issues and conditions are an expectation, not an exception. And if that was all that sunk in, that is great, because it is not, the complex case is not the exception. It is the expectation. And the foundation for recovery partnership is an empathetic, hopeful, integrated, strength-based relationship. So it's really working together with hope and integrating all of the parts of that person's recovery and looking at what their strengths are and the ability to move forward. So another principle is that all people with co-occurring conditions are not the same. So everyone with a substance use disorder is not the same. Everyone with mental illness is not the same. And certainly all of the different issues, a person who's homeless, their issues in that, around that homelessness are different. So no matter what part of the system or how somebody reaches out for help, that every part of the system has to be co-occurring capable. So if a person is attending an addiction treatment program, that program needs to be capable of treating the other components, the other co-occurrences in that individual's life. And the same goes for mental health treatment. It has to be accepted that many people receiving mental health treatment also have substance use issues. And when co-occurring issues and conditions exist, each issue or condition is considered to be primary. So it's not like, hey, let's deal with this, we'll put that on the back burner, and then when this is better, then we'll talk about that. Because when someone is, for example, receiving treatment for addiction, they, go through detox, they're in a safe environment, and symptoms of the mental illness reoccur without treatment, they reoccur. Well, what was the coping mechanism for that individual to begin with? It was substances, and that is a open door for relapse. So looking at issues together for the treating program or therapist, but also for the individual, for them to learn how the various areas in their life work together or work against each other, but the sort of interplay of them. And let's see, so each condition is considered to be primary, that it's not that one gets treated before the other. So recovery involves moving through stages of change and phases of recovery for each co-occurring condition or issue. So the stages of change are referring to motivational interviewing, and that someone may be ready to change some aspects and not ready to change other aspects. And that really needs to be looked at separately. Someone may acknowledge that they have a substance use issue and they realize I need to go to detox and I need to stop, with my substance use. If they're not at a point where they're acknowledging how their mental health has played into that and how their mental health impacts their life, well, then they're at a different stage of recovery with that. They're at a different stage of change. So having the person be aware of what stage of change that they're in, or you're aware of what stage of change they're in, and helping people move through those various stages of change for whatever's going on with them. But they may be way out there, far ahead with one, and not there yet with another. And I think that I see that with co-occurrence with people. The substance use is kind of concrete and easier for someone to kind of quantify or deny if it's an issue. And the mental health issue is something that they hope is going to go away. Maybe it'll go away when they stop using their substance, and without really giving a lot of thought to how that started to begin with. So progress occurs through adequately supported, adequately rewarded, skill-based learning for each co-occurring condition or issue. And again, each one needs to be addressed separately. Sometimes it's skill building, sometimes it's insight, sometimes it's motivational interviewing, but each one needs to be dealt with separately and have the individual move forward with each one. So recovery plans, interventions, outcomes must be individualized. So there's not like a one-size-fits-all dual diagnosis program or an intervention. It really is looking at the issues that individual is dealing with, what are the co-occurrences in their life, and looking at where the individual is with each of them, and how can they all be addressed. And this model, it's designed so that all policies, procedures, practices, programs, the clinicians, everyone is trained to become welcoming, recovery, or resiliency-oriented and co-occurring capable. And that is, yes, they're talking about the clinicians, they're talking about the policies and procedures, but they're also talking about the person who answers the phone and takes the initial call and is the person who tells the person calling that they have a complex case. So, it's really, everyone needs to have that level of understanding that life is complex. And when someone gets into a situation where they are dealing with life in a non-productive manner, then all of these issues need to be looked at together, but with hopefulness and with the belief your staff need to believe, your family needs to believe that you'll get out of this. There's a way to move forward with this. There are skills I can learn. There are resources that can be accessed, that the person will be able to move forward. So being a family member, I throw in the importance of family involvement. I think that for many years in treatment, the family has been kind of scapegoated. But as a family member, we know that our loved ones, the long-term support that they're going to have, the support they're going to need for the rest of their life for these issues, comes from the family. We're there forever. Your case manager's not there forever. Your treatment program's not there forever. So families really need to be supported in knowing how to support the individual and educated on how to best provide the support. Our healthcare system does not adequately support individuals with chronic long-term needs. Things are very short-term goal-oriented. Your outcomes are brief, your 30-day outcome or 2-month, or they're not tracked over a person's lifetime, and yet we know that mental illness and substance use disorders are lifetime issues that people deal with. Hopefully they stabilize and they're not dealing with them on a critical level throughout their life, but nevertheless, they are something that a person carries with them throughout their life. And secondary trauma, and as I had alluded to, the trauma of, for example, being told that your case is complex and we can't serve you, you need a higher level of care. Some of that can be reduced with the support of the family, who is hopeful, who can maintain that hope, can maintain like, okay, maybe that wasn't the right setting or this wasn't the right therapist for you, but I'm still hopeful. There is an answer. We will get somewhere. You are, not to say these words, but you're not a hopeless case. We need to give our family members that message. They're not a hopeless case. Intergenerational ACEs. So I didn't really talk about ACEs. Again, that is trauma experienced before the age of 18. And some of that is intergenerational, particularly with minority groups. But that can be mitigated. ACEs can be mitigated. So childhood trauma can be mitigated by support when the person is in their adulthood, the right kind of support, and families can help to mitigate that trauma. So for resources, I am the executive director at NAMI, and I think NAMI, I can point, has some very good resources for family members. We have a class called Family to Family. All of NAMI's programs and services are delivered by someone either with a mental illness or their family member. So the Family to Family class is taught by 2 family members of someone with mental illness. We have a family support group that is led by family members of someone with a mental illness. And in both of those, the issue of co-occurring substance use disorder is a prominent part of all the discussions. And then there is CRAFT. which is an evidence-based program that teaches family members how to be supportive of their loved one who has a substance use disorder. Be supportive, but not enabling. So that craft is coming soon to Palm Beach County. I'm very excited about that. So we hope that we're having a train the trainer here. So soon craft will be available in our community. And then here are the resources for our NAMI Palm Beach County. And Allies in Recovery is the organization that has a craft website. And it's Q&A time.
All right. Thank you so much, Marsha. And it is, in fact, question and answer time. Thank you, everyone, for dropping your questions into the chat. So we will be going ahead with our first one. So Marsha, one of our guests tonight asks, how can I best support a family member with a co-occurring disorder?
Well, a short answer is remain hopeful, help them find the best support and treatment for their co-occurring issues. Don't put one off and move to try to mitigate one before the other. And I think, again, every mental illness, every substance use disorder is different. So, but I think it's important to listen to that individual and hear from them what their needs are and make sure that those needs are being met, and always just remain hopeful that there is an answer. You can help them move forward. Okay. And the craft class, when we have that, that'll be great.
Yes, really excited about that craft training. Please keep an eye on your emails for more information. So our next question, are people with mental illness treated differently than those diagnosed with a personality disorder?
Well, a personality disorder is a mental illness. So personality disorders do have a certain stigma to them, but it is a mental illness. The treatment is often different, but it's still, it requires assessment and treatment from an appropriate professional.
Thank you. So our next question, one of our audience members says, I'm stuck at the percent with addiction. It seems we have more than 10% of the US population with a substance use disorder. Where do these numbers come from?
The numbers came from, I put this together a long time ago. I believe the SAMHSA website. I know I got my numbers from reputable sources, but that exactly where that one came from, I don't recall. I think it was the SAMHSA website.
So as a follow-up to that, is it fair to assume that these numbers may not be accurate because there are people living with substance use disorders?
They're self-identified. Right.
They may not
right.
have come
just
to terms.
Just like 1 in 5 with a mental illness. Right. It could be more. Those are people who have identified themselves in some manner of having a mental illness, and addiction or substance use the same. And of course, substance use is quite a range.
Right.
You have a rough week, you're on your way home, you're thinking, I am going to have that glass of wine with dinner tonight, and that's self-medicating. Where does that fall in the range? So I don't think the statistics are quite so cut and dry.
I would agree with that. So I'm actually receiving your questions from the chat as we go along, and we have one from one of our online participants. They're asking, it is sometimes very difficult to get family involved in recovery of any kind. What is the best way to approach that?
I have heard that, that line. My experience is families want to be involved. There's been historically a lot of shaming of families that they enabled their loved one. It's their, somehow, and our loved ones, when they're in the throes of their substance use and their mental illness, they are often very quick to tell us that it's all our fault as a family member. Mm-hmm. So, I think sometimes families are reluctant to be involved because they feel that they've been told they're part of the problem. Sometimes they're feeling hopeless because they are getting the message that their loved one has been in treatment 4, 5, 6, 8, 10 times, and they're feeling hopeless, and they, for their own self-protection, want to cut off contact. I'm really hoping, I mean, I'll keep throwing it out there, but I'm really hoping that having this craft model here, which is teaching families really concretely how to be involved and be supportive and not be enabling, I really believe that will be, and that's something that, that model is something that treatment programs could use and engage families through that, or families can learn it on their own.
Okay, thank you for sharing. That was a loaded question. So our next question from our online chat: how can we start a NAMI family support meeting?
Well, we have a virtual NAMI family support meeting. It's actually right now. It's every Wednesday night from, it's over, 6 to 7:30. And it's virtual. It's well attended. It's a really good group. If someone wants information about that, they could look at namipbc.org. There are also NAMI family support groups throughout the state, throughout the country. Every NAMI website lists their support groups. A lot are virtual. If you don't want to go to a Palm Beach County support group, you could go to a support group in New York, you know, another county or another state. So they're pretty readily available.
That's good to know. So our next question: what should a family look for in a treatment center if they are looking to treat a family member with co-occurring disorder?
That is a great question. When people ask me that question, I try to go over some things that maybe they should look for. The right answer for one person is not necessarily the right answer for someone else. So I suggest to people to consider their family member's diagnosis, look at the clinical staff and see if there is clinical staff that can adequately support that person. For example, if their loved one has schizophrenia, is there a psychiatrist there who not only can prescribe for someone who has schizophrenia, but is used to providing services to people who have schizophrenia? I suggest that they call and ask how often the person's having one-on-one counseling, because the majority of treatment is done in groups. And that's a surprise to a lot of family members, and often people who have fairly serious mental health issues have trouble with groups. So if your family member goes to treatment and they can't tolerate a group, and that is how the treatment program bills, they'll be told that they need a higher level of care. So it's good to know that going in and exploring that possibility. I suggest that they ask for a schedule of what their family member would be attending during the week. See what those classes or groups or see what they are. Are they things that look like your family member would benefit from? And I also suggest that they ask who runs those groups, because sometimes they're run by a licensed clinician and sometimes they're run by an unlicensed person. So that may make a difference. I also suggest to people to, if it's residential, to ask about evening and weekend staff. My experience has been that is often when an individual gets Baker Acted, if they're not fitting in. So if there is not experienced clinical staff who can diffuse a situation or interact with a situation, sort of by default, the person might get sent to the hospital and Baker Acted and often not allowed to return. So those are some of the things. I kind of, talking to the person and knowing sort of their individual history, I can help them think of different things to look for. But I guess the main thing is to say, don't take for granted that this program is just what your family member needs. You need to ask a lot of questions.
Okay, well, thank you for that. As a follow-up, when it comes to choosing a facility or a program, who gives the treatment? Is it people in recovery, like peer support? Is it always a therapist?
Who gives the treatment?
Like who is, right, that's our
Who
question.
provides the
Who provides
treatment?
the
Yeah,
treatment?
I mean, it really varies.
vary?
It's, yeah, I'm not a treatment provider, but, you know, I certainly have seen really great treatment provided by trained peers, and I've seen really great treatment provided by PhD level, you know, and I've seen bad on both ends too. So, you know, it's, you know, you want someone who is trained and that your loved one relates to and understands what the issues are, the multiple issues are with your family member. So it really, you know, different levels of treatment have requirements for different licensing and staff as well.
Okay, so kind of follow up on that, on this track of just talking about peer recovery. Do you know the statistics of peer-based recovery?
I am not good at remembering any statistics on anything. So, but I do know that peer-based recovery is evidence-based, that peer support is effective. And I can say I have seen situations where it has made a difference of life and death. And for my family member, my loved one, there were times that the only person who would relate to them was a peer. His peer stuck by him and talked to him when no one else would. And I really believe that may have made the difference in life and death.
Okay. So our next question is the main difference between CCSI and CBT therapy that CCSI is more individualized and focused on the individual's
I'm
needs?
not a therapist.
Okay.
I'm a mom. I'm a program director. You know, no, I'm not a therapist.
Okay, well, thank you for answering that. And the next question, do you prefer interventions or Marchman Act?
You know, involuntary anything is usually traumatic. But sometimes things have to be done involuntarily to save a life. An intervention, the person is given a choice. You know, hopefully they may be, you know, I say sort of strong-armed into a choice, but they are convinced to make a decision. And Marchman Act is a pickup, typically. You know, the person comes and picks up the individual.
Correct.
So in that sense, theoretically, an intervention might be less traumatic to someone. But, you know, we have to make those choices. If our loved ones' lives are in danger, we make the decisions we have to get them out of danger. And it's not easy.
Well, thank you for that. And it's probably a difficult one.
It is difficult.
And our next question, how do you help someone who's in denial? What are the best ways or methods to sort of approach them?
Well, there are a couple answers to that question. One, I will talk about just specifically from an issue of mental illness. Someone who's living with schizophrenia, so the person is having delusional thoughts, maybe psychosis, maybe hallucinating, and we see that they need help, and they say that they don't need help, and we may say that's denial. In schizophrenia and in some bipolar disorder, that is called anosognosia, and that it's lack of awareness, and that is actually part of the disorder. So it is part of the change. The brain structure it's not allowing the person to see their own situation accurately. So it's anosognosia, and that is not denial. It's lack of awareness. So aside from that, then I'll set that piece aside. If someone is using substances or they're having personality issues, that they're in conflict with people or anger, anxiety, and they're denying that those are issues, there's a technique called motivational interviewing that is highly effective, and it has been shown to move the most difficult populations, and they've looked at this with people with incarceration histories, histories of homelessness, histories of mental illness and addiction, it has been demonstrated that it will move them towards accepting, towards wanting to change. It doesn't happen overnight. It's not quick like a Marchman Act. It's building a relationship, rapport with that person, and being able to have them start to acknowledge and see what some of the issues are and move forward. In Palm Beach County right now, we have a very large contingency of peers who are going through, just finishing up 9 months of motivational interviewing training.
Wow.
And it's like a PhD level course. It's really amazing. So a number of our programs that have peers working in them, the peers are going through that training. And that's for 9 months, and then the last 3 months, the organizations that are employing peers will have some of their own employees become trainers of motivational interviewing. So they will be able to train staff ongoing in motivational interviewing. So this motivational interviewing, it is the way that we get people to move forward. We can help someone who doesn't want help, but it doesn't happen overnight, but it absolutely is possible through motivational interviewing.
Okay, so just kind of in that same vein as we talk about motivational interviewing, what are some ways a person could go about obtaining this training or this certification? What organizations currently offer this?
Motivational interviewing?
Yes.
Actually, evidence has shown that the quick 1 day, 1 week trainings you can learn about motivational interviewing, but the people who take a 1 day or 1 week training end up not really using it. That's why, we have a grant from the Harris Foundation that's doing the 9-month training, and that's why we have that grant, because it takes that long to change your own way of interacting with someone. It's how you're relating to that person, and therefore how they relate back to you. But people can learn about motivational interviewing. You can pick up some of the techniques, I'm sure. There are books on Amazon. There are workbooks on Amazon. I'm sure if you Google it, you can find workshops on motivational interviewing. But again, it's changing you, the person who's talking to that individual. So you have to learn to change your way of interacting.
Okay.
Which doesn't happen overnight.
I'm sure. Well, actually, Marsha, those were all of our questions.
All right, that's more than I thought we'd have.
That's all that we had from the chat and from our live audience. Thank you so much for your
thank
time
you. Thanks for having me here.
No, thank you so much. All right. Well, thank you everyone for joining us for the 5th installment in our series. Be sure to join us next week as we speak with Marchman Act attorney Joe Considine, and we talk about substance use disorder and the intersection with civil commitment issues. I just want to remind everyone who is attending virtually that we do have a survey for you to complete. It will be dropped into the chat, and those that complete it will be entered to win a $25 Amazon gift card. So thank you for your attendance this evening, and just have a wonderful night.